So hello all, welcome to a new edition of Vertical Integration. So again, it's one of the very important undergraduate topic that we are going to discuss today. It is breast lump. So we have an expert panel here. So over to my right, we have Radhi ma'am, who is the professor of anatomy. And to next, there is Dr. Jolsna, he's associate professor of pathology, and we have Dr. Anjali, who is assistant professor from the Department of General Surgery, and we have Dr. Lakshmi from the Department of Radiology, who is the administrator and associate professor in the Department of Radiology. So with this background, let's start the ball rolling with the first question to Radhi ma'am. Ma'am, can you just briefly describe the gross anatomy of breast, of the mammary gland?
So the mammary gland is actually, its main function is to produce milk for feeding the infants, and it's also having some importance for the sexuality of the women. And here, if we are looking at the mammary gland, it's a type of modified sweat gland which is present located in the superficial fascia or the anterior chest wall. And it is actually present on the pectoral fascia. Pectoral fascia is the fascia, deep fascia, which is covering the pectoral muscles. And when we are looking at the extent of the mammary gland, it is extending vertically from the second rib to the sixth rib, and horizontally it is from the lateral border of the sternum to the mid-axillary line. And it is having a hemispherical shape, and its size and all differs according to the genetic character and food habits and all. But then it's just having a base and an apical region, and at the apex is the nipple. Its base actually it is resting on the pectoral fascia. When we are looking at the base, in between the base and the pectoral fascia, there is a space which is filled with loose areolar connective tissue. Because of this loose areolar connective tissue, the gland as such is mobile on the chest wall. But then if some pathological conditions like a cancer occurs, there are some reasons for the mammary gland to get fixed on the chest wall that we will look into. And here this space is called as the retromammary space. And the gland as such, if we are looking at, it is having three parts in it. Means it is mainly composed of the glandular tissue, which makes the parenchyma, and then the stroma. Stroma means it is the fibrofatty connective tissue. And this structure is covered by the skin. The skin on the surface shows at the center the projectile part, that is the nipple, and around the nipple there is that deeply colored area which is called as the areola. On the nipple, many lactiferous ducts, means 15 to 20 lactiferous ducts are opening, and these lactiferous ducts are actually coming from the different lobes of the mammary gland. We are looking into the parenchyma now. The parenchyma means it is the glandular tissue. So the lobes, 15 to 20 lobes are there. Each lobe is drained by the lactiferous duct. And the lactiferous duct, if we are looking at, it is having many branches, and at the terminal ends of these branches, the secretory lobules are there. And these secretory lobules will be secreting the milk, which will be passing through the lactiferous ducts. And the lactiferous ducts are opening on the nipple. But just below that areola, this lactiferous duct is little bit dilated, and these are called as the lactiferous sinuses. When milk secretion occurs, these lactiferous sinuses will be collecting the milk. And in between this glandular tissue, which is tubuloalveolar type of glands, in between these glandular tissue, the fibrous tissue is there. And this fibrous tissue is getting thickened, and these thickened strands of the fibrous tissue is getting attached to the skin as well as deeply to the pectoral fascia. When it is getting attached like this, and there also, if the cancerous growth occurs along this fibrous tissue, this will be actually making some or giving some signs on the skin. Now, this fibrous tissue which is making the attachment to the skin as well as to the pectoral fascia is actually acting as suspensory ligaments. These are named as the suspensory ligaments of Cooper. And this actually makes that mammary gland fix, not actually pendulous, not pendulous, it is actually connecting that or keeping the mammary gland in position. When they get loosened or they are weaker, then that pendulous mammary gland occurs. And now if we are looking at the duct system, and the duct system is actually opening on the nipple, I said, and that much is about the gross anatomy.
Okay, thank you. Okay, so next question to Dr. Jolsna. Can you just briefly let us know what are the common benign breast disease and a basic pathology, what an undergraduate should know about this?
Okay, so regarding benign breast pathologies, like any other organ, we have non-neoplastic conditions, and then we have a few common tumorous conditions like fibroadenomas, which are benign. So when we are talking about inflammatory lesions of the breast, they are generally rare, and the common causes are infections, like you get in a lactating breast an abscess due to Staph aureus, or maybe a rare TB infection, tuberculosis. Or it could be secondary to other inflammatory conditions like autoimmune diseases. You can have sarcoidosis, you can have lymphocytic mastopathy in type 1 diabetes. It also has an autoimmune kind of etiology. And then you have granulomatous lobular mastitis, where you have a granulomatous inflammation. In addition to these, sometimes you get inflammation secondary to rupture of a dilated duct due to the release of secretions from a dilated duct, as in duct ectasia, or maybe keratin which is coming out of a duct which has squamous metaplasia, or so on. After inflammatory, one very important non-neoplastic condition is fat necrosis, which is usually secondary to trauma or an intervention like surgery. The problem is it can mimic a malignancy clinically and radiologically. So here it's basically liquefactive necrosis of the fat with surrounding inflammation. And then we go to the important group of epithelial lesions, which are benign. So under this comes the very commonly encountered fibrocystic changes of the breast, probably related to hormonal changes, where you have cystic changes in the ducts, you have fibrosis, you have some amount of epithelial proliferation in the form of adenosis. Other than that, you have epithelial proliferative lesions with atypia and without atypia. So in the group of proliferative epithelial lesions without atypia, you have different kinds of hyperplasias, like usual ductal hyperplasia. Then you have some benign papillary lesions which can produce secretions, which can produce a discharge from the nipple like papillomas. Then you have rare fibrosing lesions like a complex sclerosing lesion or a radial scar which is picked up on radiology and which can also mimic malignancy. So those are proliferative lesions, epithelial proliferative lesions without atypia. And then you have some proliferative lesions which do show some degree of atypia, like your atypical duct hyperplasia or atypical lobular hyperplasia. So all these are almost benign, but they are associated with slightly increased risk for malignancy as against normal women who do not have any of these pathologies. But the increased risk is probably very little, a lifetime risk of maybe 3 to 15%, that's all. But along with these benign conditions, I'd also like to mention about the very commonly encountered fibroadenomas and the benign phyllodes tumors, which fall into a separate group of fibroepithelial lesions, where you have proliferation of the epithelial component as well as the stromal component. So fibroadenomas are probably the most commonly encountered lumps in breasts, especially in younger females. And towards older ages, we have benign phyllodes tumors, which are also fibroepithelial lesions.
Okay. Thank you. Dr. Anjali. Anjali, can you just, what are the common symptoms and signs of various breast pathologies? Just giving an overview.
So the common symptoms with which most of the patients come to our OPD would be definitely a breast lump. There are as well as other symptoms, but the most common symptom would be a breast lump. So if a patient is coming to the OPD with a breast lump, we should probably ask questions related to the lump, like when was this noticed? How did she notice the lump, and what was the size when the lump was noticed, and what was the rate of progression of the size, which is very important. And then are there any associated symptoms with the breast lump, like pain? Most of the students often misunderstand pain as a symptom of a malignant breast lump. No, pain is not a classical feature of a malignant breast lump. And another symptom with which a patient can come to the OPD would be a nipple discharge. So again, you will have to probably ask the patient about when did she notice the nipple discharge? Is it present on both the breast, or is it confined to one particular breast? What is the color of the discharge? All those details are very important, because there are different types of nipple discharge, like a blood-stained nipple discharge. Blood-stained nipple discharge can be seen in a patient with a malignant breast lump, or it can even be seen in a benign condition like a duct papilloma. So if a patient is having a blood-stained nipple discharge, it need not always be a malignant lump that we are dealing with. It can be a benign condition also. And there are other conditions where there can be discharge from the nipple, like there can be ductectasia, or even a lactating mother can present with a milky discharge from the nipple. And another symptom with which a patient can come would be a nipple retraction, otherwise called an inward pulling of the nipple. So it can be a physiological also. So again, you will have to ask about when did she notice this nipple retraction? Was it present from the childhood? There are different types of nipple retraction, like a slit-like nipple retraction or a circumferential. Usually the circumferential nipple retraction is what we see for a patient coming with a suspicious or a malignant breast lump. And if physiological would always be a slit-like nipple retraction, and probably you will have to go and check the other breast also. Then there can be other skin changes that can happen to the breast. Sometimes a patient can present with scaly lesions over the breast. So we might be dealing with just an eczema. So probably we'll have to go and ask the patient, do you have any history of eczema? Whether there are any scaly lesions elsewhere in the body, or is it confined to that particular breast? Sometimes we have all heard about something known as a Paget's disease of the breast, where scaly lesions over the breast would be the starting of a Paget's. Later, the entire nipple areolar complex would be replaced by an ulcer. So scaly lesions, if you're dealing with that, you should always have a possibility of an eczema as well as a Paget's disease of the breast. So these are the few commonest symptoms that we usually see in our OPDs.
Okay. Thank you. Over to Dr. Lakshman. Can you just elaborate what are the various modalities of radiological imaging available for a breast lump evaluation?
Okay. For breast imaging, when a patient present with, as per the symptoms which is said by Dr. Anjali, basically 3 imaging modalities are there. First one is ultrasound, second is mammogram, and third is MRI. So ultrasound is the primary imaging modality of choice for young women with dense breast. Ultrasound obviously help us to characterize the lesions which we pick from mammogram, whether it is solid or cystic lesions. It will give the definite clear-cut idea about the margins, the vascularity, Doppler flow, color flow. So first one is an ultrasound imaging modality, and ultrasound is basically used for young females, especially less than 35 years of age. Second thing is mammography. So initially we used mammography for women with above 40 years of age. So basically mammography means it's an X-ray of the breast. So initially and all we had 2D mammography. Under mammography there are, again we categorize into normal 2D mammography, which is almost outdated now. The second category coming under the mammography is 3D mammography, also known as digital breast tomosynthesis. This is actually, we'll take multiple images of a breast from different angles, and we will synthesize to an image where we'll get a 3D image, where only 1 millimeter slice of the breast is able to see in the mammogram. Basically, it is a mammogram only, but it's a 3D version of the mammogram. Third and the latest advanced technology is a contrast enhanced mammography, where we'll take a digital mammography. Along with that, we will inject IV iodinated contrast to the patient and we'll get an image. That is a contrast enhanced mammography. The added advantage of the contrast enhanced mammography is it will give the morphological and functional information of a mass. So all the, usually in young females have dense glandular parenchyma. So even in 2D and 3D mammogram, we'll be seeing dense gland. So lesion has to be fit within this dense gland. The mammogram image, the X-ray image of the breast is like, you'll see fat and a gland, and the gland will look white on the X-ray image. but the lesion, even if it is a benign or the malignant lesion, the lesion also is looking white. So the tougher part is we have to pick a lesion, either it is a benign or malignant, the white looking appearance from a white looking gland. Basically, we have to pick a white lesion from a white background. So the added advantage of contrast is when we give contrast, this gland will get suppressed. Only the mass, either it is benign or malignant, that lesion will be projected out. So these are the types of mammogram. It's not the types, it's the as the technology advance, this is the latest advanced technology right now we are doing. So we had 2D mammogram, 3D mammogram and contrast enhanced mammography. And third thing is the MRI. Of course, if the mammogram or the ultrasound is inconclusive or a radiologist is not able to interpret or not getting complete result from these two imaging modalities, the next step is an MRI breast, which we can use for many indications are there, like basically for young female with high risk screening, like a female with a family history of breast neoplasm in multiple members, or if she is a BRCA positive or any other genetic mutation positive, MRI is the first choice. Second thing is for if we find out a tumor, that if we diagnose a cancer, then to know whether it is multifocal or multicentric, MRI is the better imaging modality. And third thing is for response assessment following a chemotherapy. And fourth indication is a problem solving tool. If, as I said earlier, if there is inconclusive, the imaging from ultrasound and mammogram is inconclusive, we use MRI breast as a problem solving tool.
Over to ma'am again. Ma'am, can you just elaborate on the blood and the venous drainage of the breast?
Blood supply, that includes the arterial supply as well as the venous drainage. And for the blood supply, means arterial supply, if we consider, this will be actually the blood vessels, means arterial arteries which are on the chest wall itself, means anterior chest wall, mainly axillary artery, and then the internal mammary artery. And axillary artery is having 3 parts, and the first part is giving that artery which is called as the superior thoracic artery, and the second part gives 2 branches. Out of that, one will be the thoracoacromial artery, so it gives some pectoral branches, means thoracic branches, and then the lateral thoracic artery, which will be giving some mammary branches from the lateral aspect of the mammary gland. So main arteries will be the axillary artery through its 3 branches itself, that is superior thoracic, thoracoacromial through the thoracic branches, and then the lateral thoracic artery. Even subscapular artery also gives some branches. Then the internal mammary artery, this gives anterior perforating branches to the mammary gland, and these are the main arteries supplying. One more set of arteries are there. These are from the posterior wall itself, means the chest wall, intercostal arteries. Second to fourth intercostal spaces, the posterior intercostal arteries are there. They also give the branches from the deeper aspect of the breast. Then venous drainage, when we consider, all the veins are actually radiating from the areola, because under the areola and in the areola region around that, there is a venous plexus. This venous plexus will be the beginning from where the veins will be radiating, and they will be drained through these main veins which are running along with the arteries. That means through the axillary vein, internal mammary vein, and the posterior intercostal veins. But the posterior intercostal veins are having more important role because they are connected with the vertebral venous plexus of Batson. So through the vertebral veins, that means if some cancerous growth occurs, that will be spreading through this venous drainage, mainly through the vertebral venous plexus. So it will be giving metastasis to the bones, to vertebra, and then to the skull and clavicle and all other bones. Okay. So this is about the blood supply.
Thank you. Dr. Julsna, again, can you just elaborate the pathological and molecular subtypes of breast cancers?
Okay, so breast cancer is probably one of the most important pathologies of the breast. So before going into the pathological and molecular subtypes, just briefly regarding the risk factors is an increased exposure to estrogen. So maybe early menarche, late menopause, nulliparity, late first child, And then other risk factors like exposure to alcohol, postmenopausal obesity, and now the increasingly recognized hereditary predisposition syndromes like the BRCA, P53 and so on. So now coming to the pathological subtypes. Basically, like ma'am said, the TDLU or the terminal duct lobular unit is the basic functional unit, and it is composed of numerous small ducts which have a luminal epithelial layer and an outer myoepithelial layer. Now, why I'm telling about this is because when you're talking about carcinoma, you have something called a carcinoma in situ, which is, in terms of breast, the most commonly used terminology would be a DCIS or a ductal carcinoma in situ. And then you have the frank invasive carcinoma. So long as this abnormal epithelial proliferation arising from a duct is confined within the myoepithelial layer, or it has not gone out of the duct in which it is growing, it is referred to as an in situ carcinoma. So it could be either a ductal carcinoma in situ or a lobular carcinoma in situ. LCIS is less common, not going into the details of those. And once it breaks this myoepithelial barrier and gets into or infiltrates into the surrounding stroma, it becomes a frank invasive carcinoma. So when you're talking about the histologic subtypes of invasive carcinoma, there are many subtypes based on the morphology that we see under the microscope of the lesion. So the most common one is actually the invasive breast carcinoma, no special type. That is the terminology that has been given by the WHO classification of breast tumors. So this encompasses actually a wide group with slightly different morphologies also, but that is the most commonest group. Other than IBC NSTs, we have less common subtypes like invasive lobular carcinoma, mucinous carcinoma, cribriform carcinoma, secretory carcinoma, metaplastic carcinoma, and a whole lot of other named variants which are much less common. Now, what is more important than just identifying the histologic subtype in case of a pathology report would be the grading of the carcinoma based on morphology, wherein we look at three different aspects. One is the amount of what is known as tubule formation, because most of these carcinomas of the breast are adenocarcinomas, as would be expected in a secretory organ. So adenocarcinomas, we always learn that the main feature is tubule formation. The better differentiated they are, more is the tubule formation. So the grading of breast cancer is usually the commonly used grading system is modified Scarf-Bloom-Richardson grading, wherein we use three factors. One is the amount of tubule formation within the tumor, then the degree of nuclear atypia, which we see under the microscope, and the amount of mitosis or the proliferative activity. So grading is, in addition to assigning the histologic subtype, grading is also done based on morphology. So molecular subtypes, can I tell you after the ERPR, HER2?
Yeah, we can discuss it.
So this is about the general morphology of the breast cancer.
Thank you. Over to Anjali again. Can you just elaborate what are the clinical examination that you will do when a patient comes to you with a breast lump?
So before moving to the clinical examination, once you're done with the history, you go to a general examination, and just before going to the local examination, you have to position the patient. Positioning of the patient is very important because breast is examined in different positions. Like patient is examined in sitting position, a semi-recumbent position, and a recumbent position. And exposure of the patient is very important. You should take a consent before touching the patient. You should explain about how the examination is being done. And if a male doctor is examining the patient, it should always be in the presence of a female bystander or a staff nurse or a colleague. So the exposure, there should be an adequate exposure, the entire thorax, including your upper limb, the arm, the supraclavicular area, both the breasts should be adequately exposed. And then first is inspection. So when you're inspecting, the patient should be ideally in a sitting position, and both the breasts should be inspected together. So if you want to know that there is an abnormality on one breast during an inspection, you should always compare it to the other breast. Then only you will be able to appreciate. You may not be able to appreciate a breast lump on inspection. That is most commonly we'll be able to appreciate it only during a palpation. Sometimes during an inspection, all we'll be able to see is just a fullness. We all know that the breast is divided into 4 quadrants: the upper outer, upper inner, lower outer, and lower inner quadrant. So when you are inspecting, when you compare one breast, the pathological breast to the normal breast, sometimes you will be able to see a fullness on one particular quadrant where the lump is actually there. So that is all you will be able to appreciate during an inspection. So later on you go to the next palpation, you will be able to get the details of the lump better. Then there can be other skin changes that you will be able to appreciate during inspection, like what is called as a pude orange appearance. Pude orange is nothing but it's a skin change that you see in a malignant breast lump where a tumor infiltrates the subcuticular lymphatics and the openings of the hair follicles become very prominent, giving it an orange peel appearance, and that is why it is called a pude orange. So this is a skin involvement in carcinoma of the breast. So if you're asked about what is skin involvement in carcinoma of breast, it is pude orange appearance, or there is ulceration, or there should be a nodule formation. So only these three are skin involvement in carcinoma of the breast. There is another terminology called puckering or dimpling, which is not a direct involvement of the skin. Here, the tumor is infiltrating into the Astley-Cooper's ligament, which are nothing but the fibrous strands that are connected from the breast tissue to the skin. So what happens when you have a lump, a tumor that is infiltrating onto the Astley-Cooper's ligament, this is going to pull the skin inwards, giving it a dimpling. So this is a dimpling or a puckering is just an inspectory finding, and where there is no direct involvement of the tumor to the skin. So only when there is a pude orange, ulceration and nodule formation, there is a direct involvement. And in addition to inspecting the breast, you should always go and inspect the axilla, look for any nodules there or any swellings there. You should always inspect the supraclavicular area for any swellings over there, because definitely we all know if you have a tumor there, there can be a lymph node involvement in the axilla as well as in the supraclavicular area. And then when you have a malignant infiltration of the lymph nodes in the axilla, the lymphatic drainage of that particular limb can get affected, so the patient can come with lymphedema. So that also should be addressed. So always remember, inspection is always done better in a sitting position. And if you want to, check the infraclavicular area, you'll probably ask the patient to lift the hands up, so you'll be able to get a better view of the inframammary area. Okay. So this asking the patient to lift the hands up. Another important point is if the patient is having a puckering or a dimpling, when the patient is raising the hand up, that becomes more prominent. So that is the benefit of asking the patient to lift the hands up. Now moving on to palpation. Yes, now you are touching the patient. Till now you are just inspecting and seeing, and you're not touching the patient. And now then you are moving ahead to the palpation. You will be palpating the normal breast first. That is very important. You should know what is normal in that particular patient before coming to the pathological breast. And then all the 4 quadrants should be palpated, and never forget to palpate the area behind, underneath the nipple areola complex. And suppose you get a lump in particular quadrant, you should be able to locate where, you should be able to document where the site of the lump is. So that is usually documented as, if the lump is in the upper outer quadrant, a particular quadrant should be mentioned, as well as at which clock position and how many centimeters away from the nipple areola complex. So that makes the location of the lump complete. Just mentioning about the quadrant is not sufficient. Then you will have to mention about the shape of the lump, about the margins, the consistency. So consistency is very important when you are encountering with a hard lump. Probably you will have to think in terms of a malignant breast lump, especially when you are checking the mobility and you feel that the lump is fixed within the breast tissue. It is not moving freely like a benign breast lump, then we will probably have to think in terms of a malignant breast lump. Another thing is something called a tethering. That is the most commonest question UGs are asked always. What is tethering? This is again a condition where the malignant breast lump, a breast lump which is malignant, is infiltrating into the Astley-Cooper's ligament, and this is a palpatory finding. This is something we are eliciting. You try to move the lump to either sides, and at the extremes of movement, you will be able to see the inward pulling of the skin. So that is something we are eliciting. So the reason behind tethering is the same as puckering, where the Astley-Cooper's ligament is involved. The difference is puckering is an inspectory finding, while tethering is a palpatory finding. And then talking about fixity of the lump. A fixity of the breast lump, there are 4 types of fixity. One is fixity to the skin. You check fixity to the skin by pinching the skin and seeing whether you're able to pinch or not. Then second fixity is fixity within the breast tissue. That is, you hold the breast with one hand and then you try to move the lump within the breast tissue using your other hand. And if you're seeing that there is some restriction of movement within the breast tissue, which is definitely seen in a malignant breast lump, then probably you're dealing with a malignancy. Probably. All the confirmation can be done only by doing investigations. Then the third fixity is fixity to the underlying muscles. So that probably you'll have to ask the patient to keep the hands over the hips and then exert some pressure over the hip and see whether your axillary fold is taut, anterior axillary fold is taut, which by that we know that the pectoralis major is contracted, and then try to move the lump. So initially the lump might be mobile, but after doing this particular maneuver, there is a restriction of movement of the lump. Then we know that there is some kind of a muscle infiltration of the lump. And the fourth fixity is fixity to the chest wall. Irrespective of doing any maneuvers, the lump will be fixed. So these are the 4 types of fixities. So with this, we come to the end of palpation of the breast lump, and then probably you'll have to go to the palpation of the axilla, palpation of your arm, palpation of the supraclavicular area to make it complete. And after that, please do not forget about a systemic examination. We all know that if you're dealing, especially you're dealing with a patient with a malignant breast lump, definitely you should always go for a systemic examination to see whether there are any clinical features of metastasis.
Thank you. Lakshmi again. Whenever we read a radiological report, we see something called a BI-RADS classification. Can you just elaborate what is this BI-RADS classification?
So, American College of Radiology has introduced a BI-RADS system. BI-RADS is basically breast imaging reporting and data system, and currently we are using the 5th edition of BI-RADS. The 6th edition will be coming soon in this next year, early it will be coming soon. So it is actually a reporting system. It gives a uniformity and objectivity in reporting, in the interpretation of whatever imaging modalities, like whatever we are reporting in mammogram, ultrasound, contrast enhanced mammography and MRI. So all these 4 imaging modalities have BI-RADS. It is actually, there are 6 things, BI-RADS 0 to BI-RADS 6. So BI-RADS 0 means the imaging conclusion we are obtaining from the particular imaging modality is inconclusive. Means you need additional imaging to come to a conclusion. That is BI-RADS 0. BI-RADS 1 means it is a negative, means it is that particular study you are doing is normal, either it's ultrasound or mammo, whatever it is, it's a normal finding. That particular patient can do an annual follow-up. BI-RADS 2 is a benign finding, like when you see a simple cyst, okay, it is BI-RADS 2. Again, the patient can come for a regular annual follow-up, that is enough. And biopsy proven fibroadenomas comes into BI-RADS 2 category. Whereas BI-RADS 3 is basically probably benign, means there is less than or equal to 2% chance of that particular lesion to turn to a malignant lesion. So probably benign means we will put that particular patient into follow-up, like we'll call that patient for 6 months, then 12 months and 24 months. That is the regular follow-up category. BI-RADS, next is BI-RADS 4A. Okay, coming to this BI-RADS 4A, this is kind of like again it is subdivided into 3 categories. BI-RADS 4A, 4B and 4C. 4A means it is like more than 2 but less than or equal to 10%, low suspicion of malignant lesions, but it's the category is like more than 2 but less than 10% chance of getting malignant. BI-RADS 4B is more than 10 but less than 50%, and BI-RADS 4C is more than 50 but less than 95% chance of getting malignancy. Basically 4A, 4B, 4C, low suspicion, moderate suspicion and high suspicion for malignancy. When the finding is fitting into BI-RADS 4 category, definitely we have to do a biopsy and make it to a conclusion. Next is BI-RADS 5, means highly suspicious, highly suggestive of malignancy, like imaging findings, like from mammogram you will be, for a malignant lesions, it will be classic spiculated, indistinct margins, microlobulated margins, irregular mass. Those all category come into BI-RADS 5. in ultrasound, if you take, okay, again the same thing, indistinct spiculated margins, high vascular flow, that elasticity will check in ultrasound, that'll be hard on elastography. So those sort of and in contrast enhanced mammography, for a malignant lesion, the tumor will pick up, for contrast and MRI, the malignant lesions will show early contrast pickup, contrast enhancement, and it show washout. So these are the few imaging findings which are suggestive that, okay, this is a BI-RADS 5 category. Definitely we have to go ahead with biopsy. Next is BI-RADS 6. BI-RADS 6 means non-biopsy proven. So this is the categories included in BI-RADS, which basically it will alert the consultants who are sending the cases. Okay, then they will also counsel the patient to next step.
Thank you. Coming back to ma'am. Ma'am, can you just elaborate the lymphatic drainage of the mammary gland?
To understand the lymphatic drainage, first we'll look into the lymph nodes around the breast. There are some groups of lymph nodes in the axilla, which are arranged in 5 groups. Like their names are like anterior nodes or pectoral nodes along the pectoralis minor. Then the posterior nodes, which are subscapular nodes, and then the lateral nodes are there, which are otherwise called as the brachial nodes, and then the central nodes and the apical nodes. Like that, some groups of lymph nodes are there. Like that, in between pectoralis major and minor, some nodes are the interpectoral nodes or Roter's nodes, they are called as. Then supraclavicular nodes are there, deltopectoral nodes are there. Then along the internal mammary artery, some nodes are there, internal mammary nodes. So when we consider the lymphatic drainage of the breast, all the lymph will be draining into these different nodes. Just we will look into how they are being drained. So breast is having now 2 sets of lymphatics, that is superficial and the deep. So deep lymphatics means that this will be draining the parenchyma and the areola and the nipple. And superficial lymphatics means that is actually draining the skin alone, except that nipple and the areola. So if we are looking into the superficial lymphatics, majority of them will be draining into the axillary lymph nodes. Then from the upper parts to supraclavicular nodes and deltopectoral nodes. And from the medial aspect, actually they are draining into the internal mammary nodes. Some will be drained into the subperitoneal plexus, which will be then from there drained into the hepatic nodes and subdiaphragmatic nodes. And all these are important because this lymphatic drainage as such is important because of considering the cancerous growth or metastasis when the cancer occurs. Then parenchymatid, that is deep lymphatics. Deep lymphatics have about 75% that will be drained into the axillary nodes, mainly to the pectoral nodes. And then from the medial aspect, again to internal mammary nodes, but to the same side as well as some crosses the midline, and that will be crossing to the opposite side lymph nodes also. So if there is some cancerous growth occurring in the breast, this can be spread to the next, means on the other side also. Then from the deeper aspect, the lymphatic drainage occurs through to the intercostal nodes. That means it is actually all these lymphatic vessels are running along with the blood vessels. So all these systems will be showing that different nodes are being involved. So as Dr. Anjali was telling, when that cancer growth is doubted, the first and most important investigation or examination should be of the axillary nodes itself, I think. So axillary nodes will be showing which node, that is according to the site of tumor occurrence, like that will be that lymph node which will be first involved and all. That's the sentinel nodes. I think that a surgeon may be knowing better to find out how the sentinel nodes are included. So for the cancerous growth and the metastasis, the knowledge about the lymphatic drainage is very important.
Thank you. Dr. Jolsna, can you just elaborate the significant receptor status, the ERPR and HER2 status?
Yeah.
Where we have stopped from the last discussion, we can continue that.
Yeah. Once we get a biopsy of a mass that the clinician is suspecting to be a carcinoma, the first thing that we do is a light microscopic evaluation, and that is what I had already alluded to. That is the histologic subtype and the grading. But that is not enough for treatment. So now all of us know without the ER/PR HER2 status, you cannot proceed to start. I mean, you cannot proceed with the treatment. So basically, what we do is then we subject the biopsy to a test referred to as immunohistochemistry, where we actually look at the expression of estrogen receptor ER, progesterone receptor PR, and HER2 new status of the tumor. Along with this, we also do a proliferation marker referred to as Ki67. Now, why we do this is actually to subtype the tumor based on the pathogenesis. So, you are asking about the molecular subtypes. So, it's not possible for us to do a molecular profiling of each and every carcinoma that we encounter because it's very expensive and the facilities are also very limited. So, what we follow now worldwide is a surrogate classification that we do based on the immunohistochemistry status. So, for all breast carcinomas, you'll run an immunohistochemistry panel consisting of estrogen receptor. So basically in immunohistochemistry, we are applying antibodies against these proteins. And so if you have those proteins expressed in the tumor, these antibodies will go and bind and they become detectable. That is what is done in immunohistochemistry. So you apply antibodies against estrogen receptor, against progesterone receptor, and against HER2 new, as well as for proliferation marker Ki67. Now, why we do this is, actually broadly we have 3 molecular subtypes of breast cancer. Actually, it is evolving very fast. We have finer subtypes. We're not going into the details for the UG level. So, the first group is the luminal subtype, which is the biggest group of breast cancers, which are usually ER positive. So, they constitute the biggest group. So, they are usually ER positive, and many a times along with ER, they are PR also positive. So that is an estrogen ER dependent pathway of tumor progression. So it actually giving us an idea about the pathogenesis of the tumor also. Then, so that is about ER and PR. Basically, they are in the nucleus. So we actually look for the nuclear expression of the IHC marker. And we have scoring systems for the intensity and the percentage of cells which express ER or PR on IHC. Next pathway is actually the HER2 new amplification pathway. So when you have HER2 new gene amplification, on our IHC we use HER2 new antibody and we have a scoring system based on which we interpret the HER2 new IHC. So if it is a HER2 new amplified breast cancer, ideally it should give us a score of 3+ on HER2 new immunohistochemistry. Then there are some equivocal cases. There is a scoring system. Standard, we have guidelines how to score the HER2 new IHC. Not going into the details of those, but there is something called a score 2+, which is equivocal, wherein you have to resort to further testing like a FISH, fluorescent in situ hybridization. So if it is HER2 amplified, you know that is the pathway which is actually driving the tumor, and so it involves P53 also. And then we have the third group where ER, PR and HER2 new all are negative on IHC. So that is referred to as the triple negative group. So HER2 new amplified tumors, they come to around maybe 15 to 20%, and they can be ER positive or negative in addition to the HER2 amplification. And then we have this triple negative group, which is probably less common but the most aggressive. So triple negative tumors, they are referred to as the basal-like tumors, and now a lot of molecular profiling is going into that also to subclassify those basal-like tumors. But we are not going into the details of those. But triple negative, so why this kind of molecular classification of breast cancers is important is because it's based on these that you will decide what kind of drug is to be given. So if a tumor is a luminal subtype expressing ER or PR, hormonal therapy will work for them. If it is a HER2 amplified tumor, you have the option of giving them HER2 targeted therapy like Receptor or trastuzumab. Whereas if it is a triple negative breast cancer, there is no point trying hormonal therapy on them. You cannot give them HER2 targeted. You have to hit the tumor with strong chemotherapeutic agents. So that is the importance of molecular subtyping and the importance of doing ER/PR HER2 new status.
Okay. Again, over to Anjali. Again, we discussed regarding the radiological investigation. So, when, as Dr. Lakshmi suggested, what are the other modalities like biopsy, when you will recommend? What are the other investigations that you usually ask except the radiological evaluation?
So most of the students will be familiar with a triple assessment, especially for a patient coming with a breast lump. First would be a clinical examination, and Lakshmi Madam has already elaborated about the radiological options for a patient coming with a breast lump. So I'm just adding a few points. I think for the UGs, it's important to know what are the different methods of tissue diagnosis. So one is fine needle aspiration cytology, where using a 23 gauge needle, you put multiple passes onto a particular breast lump, and then you get cells are acquired from that particular lump, and then that is examined. And then another option is a true cut biopsy, where a core of tissue is taken, and then that is looked and checked, and then an additional information that you can get from a true cut is you'll be able to, ma'am was already explaining about the receptor status, which you won't be able to get in case of a fine needle aspiration cytology. So applying it clinically, if you are diagnosing a patient with a locally advanced breast cancer, then a true cut biopsy is mandatory for a patient, because most of the locally advanced breast cancers, we might be subjecting the patient to a neoadjuvant therapy, probably a chemotherapy before surgery. That's what we call a neoadjuvant therapy. So when you're subjecting a patient to a chemotherapy before surgery, all the receptor status, all the information will be destroyed. So if you don't have all these information prior to giving chemotherapy, then probably you will not be able to proceed with a further treatment. So if somebody asks you about the option of true cut biopsy, yes, it is mandatory for a patient diagnosed with locally advanced breast cancer. But again, can we do a fine needle aspiration cytology? Yes, fine needle aspiration cytology can be done for patients with early breast cancer. In early breast cancer, and if the patient is going ahead with a surgery first, that is very important. And if the patient is going ahead with the surgery first, you can probably take the breast lump, and then you can give it to the pathologist, and on the receptor status, we'll be able to get it even after surgery. But here in Amrita, we almost always proceed with a true cut biopsy. I think some of the examiners, they particularly ask this question about whether fine needle aspiration can be done in a patient with a breast lump. Yes, definitely, but in patients where we consider an upfront surgery and not a neoadjuvant therapy.
Okay, thank you. Yeah, definitely.
So the investigations like biopsies, what Anjali said is correct. So for UG level, you just understand few things. There are like in case of breast disease, there are ultrasound guided biopsies and mammogram guided biopsies, and of course MR guided biopsies are also there. So as I told you, the investigations ultrasound, mammogram, MRI, so all these three guided biopsies are there. So mammogram guided biopsies, again we divide into like core needle biopsy and vacuum assisted biopsy. So in mammogram we usually does this core needle biopsy, and vacuum assisted biopsy. So this is particularly done, mammogram guided VAB or CB core biopsy is done in case of a suspicious grouped microcalcification. So that is another entity where, especially where DCIS, usually early stage, will pick up as only or LCIS, pleomorphic calcifications, only grouped calcifications. So in this calcifications, we'll pick only from mammogram. In that case, we can do mammogram guided core biopsy and mammogram guided vacuum assisted biopsy. Then as Dr. Anjali said, whatever lesions, which are the palpable lesions, we will test, of course, we test from ultrasound guided, and very tiny lesions, very millimetric lesions, of course we can go ahead with ultrasound guided vacuum assisted biopsies. But the thing is, with the vacuum assisted biopsies, it's more expensive than the 14 gauge core needle biopsy. Then another is MR guided biopsy, where the lesion is picked only in MR. When that particular enhancement or a 4K is seen only in MR, we'll do MR guided biopsy. In India, very few centers were practicing MR guided biopsy. So these are the three, this thing. Then vacuum assisted excision is also there, where we usually excise biopsy proven fibroadenomas. So those are the things
Okay.
regarding the
Okay, thanks. Over to the question, the final question to you, the age-specific screening of breast disease. We have covered that.
Yes.
Can you just, for the sake of
yes,
the UGs?
okay, again I'll enumerate it. Just three things you keep in your mind in UG level, okay? Three or four categories, okay? First category is pediatric group and until the age of 30 years, okay? Of course, we have only ultrasound is the screening modality for pediatric and less than 30 years, okay? Coming to the next second category, 30 to 40 years, again ultrasound is the modality, but we can try mammogram if we are finding any suspicious lesions in ultrasound. If a particular radiologist is while doing ultrasound, he or she finds that particular lump she is seeing is suspicious, or if it is coming under BI-RADS for a category, we can ask for mammogram. In that, why mammogram? As I said earlier, calcifications are picked only from mammogram. Ultrasound or MRI, we won't be able to pick calcifications, and the extent of the calcification we will pick up only from mammogram. So 30 to 40. So first is pediatric age group and up till the age of 30. Then 30 to 40 ultrasound plus MRI. Ultrasound plus mammogram. And after 40 years, mammogram is the imaging modality for after 40 years. And as I said earlier, mammogram means 3D mammogram is the currently that has to be done. 2D has no role at all. You have to get a 3D mammogram. If again another advanced imaging is a contrast enhanced mammography. And in any of the scenarios, as I said earlier, if the reporting is if the conclusion is like again the particular radiologist want more information, then MRI is the modality of choice. Third group is the category where a woman with a BRCA positive or any other genetic mutation positive, every alternate month mammogram plus MRI has to be done. So that is the basic screening.
General population who don't have like after the age of 40, what is the recommendation? Mammogram is after the age of 40 so
years.
There is no recommendation as such. 35-year-old female, if she don't have any lump, as a routine practice, whether they need to get an ultrasound, as a like they want to do a general evaluation, general checkup.
Ideally, if a 35-year-old lady, if she doesn't have any family history, suppose she might be presenting with a pain or a lump or anything, ultrasound is enough. But if she is having a family history, like if she has family history in multiple first degree relatives or any second degree relatives, then it's better to start with a mammogram, because as Dr. Jolsna said that risk factors, our current scenario is like even younger girls we are picking up breast cancers. Our like modifiable risk factors like alcohol, like weight, like overweight, all those stuff, hormone therapy, early menstrual age, like late conception, all those stuff, risk factors are increasing. So we have been picking breast cancers in very young age. I think 24 year is the earliest age Amrita has picked the breast cancer. So that's what I told. If a particular surgeon is feeling okay, they'll send for ultrasound, and it's now the ball is in our court, or decision is in our part. We can ask them, okay, we need the radiation from the mammogram side is very less actually. It's actually 1 milligauss or 0.4 millisievert. So radiation part is don't have to bother much about the radiation. Because
above 40 years, we generally recommend
mammogram.
Right.
Mammogram means it's a combined report actually. After the mammogram, we are doing ultrasound also, and that report, radiological report, is mammogram plus ultrasound. So we are doing a correlative ultrasound for 40 plus ladies if required.
Thank you. Out to Anjali, the final question for the day. Surgical management of various processes. I think it's a huge question, but can you just, what an UG should know?
So ma'am was actually, Rati ma'am was actually talking about a sentinel lymph node. Yes. So a sentinel lymph node is this is the first node of drainage. If you have a malignant breast lump, you have already confirmed it. when do you do a sentinel lymph node biopsy? So usually we do a sentinel lymph node biopsy when you have a clinically node negative axilla. So clinically we examine the patient, there is no lymph node. We've taken a mammogram. In the mammogram also the axillary lymph nodes looks okay. And then when we do a sentinel lymph node biopsy when we are planning the patient to take in the OT in the theater. We'll do the sentinel biopsy inside the theater. And then usually nowadays it is done on the same day, morning of the surgery, the sentinel lymph node biopsy is done, wherein isosulfan blue dye is injected, and then along with that a technician labeled sulfur colloid is also injected, and then you will be able to identify the color of identify the sentinel node with the help of that blue color, as well as the node with the highest radioactivity with a gamma probe. So this is usually done only in patients where you have a clinically node negative axilla. So you identify that particular node, which is the sentinel lymph node, with a maximum radioactivity. You pick that node and then send it for a frozen section. And if the frozen comes as positive, then only you will go ahead with a axillary dissection. Otherwise, you will not do anything to the axilla. And other surgical options would be a wide local excision. That depends upon the location of the lump. There are various other factors that we have to consider before deciding whether we should go for a breast conservation options or go ahead with other options like a modified radical mastectomy or a simple mastectomy or a wide local excision. If you're going ahead with a wide local excision, you have to make sure that all the other quadrants are fine. There are no other lesions in the breast. And then another thing is, if the patient is going ahead with a wide local excision, then definitely the patient will have to will be subjected to a radiotherapy later. And then we leave a margin of 1 centimeter around the lump, and you excise the lump, and then we'll be sending it to the pathologist, and where they should confirm that all the margins are free of tumor. If suppose any of the margins are coming as positive, and again there should be a revision of that particular margin. Then in modified radical mastectomy, where entire breast tissue along with the nipple areola complex will be removed, and earlier the muscles, the pectoral muscles were also removed, but now we don't go for that radical procedure. We don't remove the muscles, and then along with that an axillary clearance is also done. So these are the few other options, surgical options, and then based on the pathological report, we'll be proceeding with, as ma'am has already mentioned about the receptor status. If this is coming as ER positive, and probably you'll have to give an option of hormonal therapy. Then some patients will be presenting with a triple negative type, where we'll have to subject the patient to a chemotherapy. And there are many other indications of chemotherapy also. If you have multiple lymph nodes, younger patient, there are many other factors also where you have to give an option for a chemotherapy. Then radiotherapy. One indication I've already mentioned, where the patient is subjected to a wide local excision or a conservation, the patient definitely will have to undergo a radiotherapy. And locally advanced, we'll be able, and few cases of early breast cancer, as well as locally advanced, the patient probably will have to go for a neoadjuvant therapy before a surgery.
Radhi, can you just tell what are the important questions that an undergraduate and an MBBS student should be preparing from this area, ma'am?
According to me, knowing anatomy is very important for not even first MBBS, but all the MBBS students, because knowing anatomy, many of the answers they can find out. Like looking at the breast itself, Dr. Anjali was telling about the signs, and these signs can be very easily understood. Like what all things they have to look for. So, anatomical basis of the signs of breast cancer, like dimpling of the skin. Dr. Anjali has said the reasons why it is so, and then the retraction of the nipple if cancer is there, when that cancer cells are invading the lactiferous ducts, and then the fixing of the tumor or that breast as such, and the purely-orange appearance, because that will be due to that stagnation of the lymph of the skin, in which there is swelling of the skin around the hair follicles. So all these reasons they should understand. That is the anatomical basis of different signs of cancer. And like that, the metastasis of the cancer of the breast to bones, like vertebra, skull, or clavicle, humerus, like that. They have to know about the venous drainage actually, and how that veins will be taking these cancer cells and taking it to the sinuses. Means sinuses, even the vertebral venous plexus, and from there how it is spreading. And these two are very important. Like that now, even though radical mastectomy is not now advised, and that muscles are not being removed also, but then I have forgotten to tell about that base of the mammary gland, which is related with the three muscles. Majority of the muscle, major part is the pectoralis major, and then laterally it is related to the serratus anterior, and then the external oblique abdominis aponeurosis. So that way they should know about the mammary bed. Then the anatomical basis of or clinical significance of the retromammary space. Then, as normal questions, the blood supply of the breast, then the lymphatic drainage of the breast. As our discussion was on these, so these are the very important questions with them.
Okay, thank you, ma'am. To Dr. Julsna, again for an undergraduate level, what all they should be expecting?
Yeah, so for theory, I think benign breast diseases are not much asked. But then we have slides of fibroadenoma to see and gross specimen of fibroadenoma. So that would be I think the main lesion on the benign side. And carcinoma as a whole is very important, even for the pathology exam. Just one point, can I just mention? Prognostic factors of breast carcinoma are very important. I'm not going into the details, but at least you should be able to enumerate the main prognostic factors, which include all that we have already discussed, like the age, obviously, histologic subtype, the grading, the ER/PR/HER2 receptor status, the proliferation index, Ki67 index, then the TNM status. Yeah, that was what I wanted to bring in. That is the tumor size, the nodal status, which all of us have already been talking about, and the metastasis. So TNM stage is there for all tumors. So in breast also, that's a very important prognostic factor. And like Dr. Anjali was telling, when the patient gets neoadjuvant chemotherapy, the response to neoadjuvant chemotherapy is also important to decide as to how the patient will progress thereafter. And then gene expression profiling studies if available. So that was just one point I want to bring in. But otherwise, carcinoma breast as a whole is very important for UGs from the pathology side.
Thank you. Okay, thank you.
Again, breast lump is the most commonest long case that undergraduates usually get. In that, usually they ask a lot of questions regarding inspection, what is skin involvement in carcinoma of breast, which is already discussed, what is the difference between puckering, what is tethering, what are the different types of fixities, and how do you do an axillary examination, axillary lymph node examination, and how do you do a supraclavicular node examination. Then once you're done with how do you write a diagnosis of carcinoma of the breast or whatever it is, breast lump, then how do you proceed? How do you manage a case wherein after as a part of a triple assessment, your radiological, ma'am has already discussed about the mammogram, what is the indication of doing a mammogram, what is the indication of doing an ultrasound, and what are the few indications where you do an MRI of the breast, ma'am has already told. And we've discussed about the diagnosis, tissue diagnosis options. And when it comes to theory, carcinoma of the breast can be a long case. Wherein a scenario can be given, you will be asked about the diagnosis, and yes, the TNM staging is very important. They can specifically ask about the T4 staging. Always it is a commonly asked questions for UGs, what is T4 staging in carcinoma of breast, and can the involvement of a breast lump to the pectoralis major and minor affect the TNM staging? That is most often asked question, and it doesn't affect the T staging. Only when the chest wall is involved, or only if the skin is involved, or if both the chest wall and skin is involved, or if it is an inflammatory breast cancer, then only the TNM staging is affected. So these are the common T4 staging. I'm specifically mentioning about the T4, where the involvement of the muscle, pectoralis major and muscle, does not alter the T staging.
Thank you. Any specific?
Okay, so most of the times, I think the UG level, you will be getting a question with an age, you will be getting a case scenario, like 40-year-old lady presenting with blood-stained nipple discharge. So that there is a clue, 40-year-old. Okay, so depending on that age, you should, this blood-stained nipple discharge. So as all of us have told, especially Anjali has told, the nipple discharge, what are the categories will come under. So you will be getting a clue like age. So depending on that age, you should think about this radiological screening modalities. You should describe that according to the age. That's what I like. Radiology side will be a sub question for
For a general surgery.
general
like-
surgery question. So depending on the age, you decide about the modality to be. And I think it's better to write the findings. For example, if a blood stain nipple discharge, so what you'll get in mammogram. So Paget's disease with DCAS, like microcalcifications will be the finding in mammogram. Ultrasound will get a single dilated duct with vascular intraductal contents, like in intraductal papilloma. So then invasive masses will be there. So like that, you should always categorize the findings. You should write ultrasound, okay, then the ultrasound findings, then mammogram, what are the mammogram findings seeing in the blood stain. For that, you should know what are the conditions which are causing the blood stained nipple discharge. And according to that particular conditions, you divide and write ultrasound, what are the findings, mammogram findings and MRI findings.
Thank you all. I think it was one of the best discussion that we had. Even Anjali was, and just why I wanted to let you know the audience, because she was just 5 minutes before the program, we have pulled her in to this vertical integration. And thank you, Rati ma'am. Thank you, Dr. Jolsna, Anjali, and Dr. Lakshmi for this wonderful vertical integration on behalf of Ahmedabad School of Medicine. Thank you.